Welcome to Unmasking Social, where we talk about building real friendships and meaningful connections without masking who we truly are. I'm your host, Sharon Baum, a speech and language pathologist with an expertise in social thinking and how it relates to autism and ADHD, specifically with our teens and tweens. Let's dive in. It is not only Better Speech and Hearing Month, it is also Apraxia Awareness Month, which means apraxia speech is being recognized this month. And my way of recognizing it is by highlighting childhood apraxia of speech and helping everyone to feel a little bit more confident in what it really is. Today, we have Nicole Kolenda, an SLP who has dedicated her life to educating the next generation of speech and language pathologists as a clinical educator, but also really honing in on the research of childhood apraxia of speech so that our clinical studies can actually lead to larger change and demystification of childhood apraxia of speech, also known as suspected childhood apraxia of speech or apraxia. Hello, everybody, and welcome back to Unmasking Social. Today, we have an amazing fellow SLP guest. I've crossed paths with her years ago, actually, for the first time, and I just saw that she was a wealth of knowledge, and now she is really honing in on apraxia at the college level as she teaches at NYU, but there's so much more to her than just that. So, Nicole Kolenda, welcome to the podcast. Please share with everybody what it is that has brought you all the way to this journey, what has preceded this, because you've lived many lives until now. So feel free to share all of it.
Sharon, thank you for having me. I think it was 2018
that we crossed paths. Yes.
I'm sitting here trying to remember, but I remember coming to your school.
Yes. I was working in a middle school in the NEST program, and I remember you stopping by with another friend and colleague of yours, Rachel. And it was just to take a sneak peek at what I was doing with some of the students at Hunter, because I was taking interns from Hunter, which I loved. I love working with the next generation. It's so phenomenal, which you probably can relate to.
Absolutely. Yeah. Yeah, I'm just like, that was such a long time ago, but it doesn't feel like it.
It doesn't feel like 8 years ago or almost a decade ago.
Not at all. Yeah, crazy. Yes. So I am currently the lead speech pathologist, treating speech pathologist on a treatment study at the NYU Motor Speech Lab that's headed up by Dr. Maria Grigos. And this was an NIH-funded R01 grant. We're actually at the very end right now. I'm actually seeing right now the last 2 kids for this one grant that we were on. And we're hoping to have a second one, knock on all the wood.
Yeah.
For the fall, but we're not there yet. So I'm finishing up this one. It's been 6 years doing that role as the lead speech pathologist on this treatment study, looking at the dynamic tactile and temporal cueing technique that was developed by Dr. Edith Strand. So we are just looking at, is this an efficacious treatment for children diagnosed with childhood apraxia of speech? So that's been like my sole mission these past 6 years. I do also teach. I teach speech sound disorders at NYU, which I've been teaching for, you're not even going to believe this, but like 24 years or something crazy.
Wow. Yeah. And like I said, the skincare routine, I don't know what you do. I don't know what you do. When I first met you, I noticed it, and now I notice it. Sorry, guys, if that's a little off topic.
Sweating. It's, it's one of those days. Jeez.
Yeah. As the cool kids say, glazing, right? Don't glaze too much, right?
Glazing.
Red alpha, I'm
I don't know, is that so cool, or we sound cringy right now? That's
we're cringy now. If they were listening to us, whoever's listening that's a teen and tween, it's probably like, oh my gosh, these people are old and silly.
Yeah, I get it from my kids. My children are 15 and 14, so
yeah, they'll cringe if they listen in.
Yes, I'm in it constantly. So I'm teaching. I also teach a pediatric neurogenic motor speech disorders class that I love at NYU. I teach a practicum class. So I'm like you. I find that the way that I stay current is through the students. Like, it's a back and forth, it's a symbiotic relationship. Like, I get it, like exactly what you're saying. So I also love that interaction. So doing the therapy in the treatment study really informs my teaching.
Interesting. So if I can dig a little deeper into this apraxia, because this wasn't necessarily something, as far as I know, that you were always honed in on, right? That sounds like you said, like, you knew about apraxia, you treated apraxia, but it seems like you really have gone in full force these last 6 years at NY.
So interestingly enough, when I was an undergrad at NYU, I know this because when I moved, I found all my papers, which were handwritten at the time. But
Oh, of course.
when I was an undergrad at NYU, I did apraxia of speech
Mhm.
as my one of my presentations. So it wasn't
Interesting.
called child apraxia of speech then. It
Oh.
was developmental verbal dyspraxia, verbal dyspraxia. It was very different then, and we're talking this was probably circa 96 or something, 5 maybe, with my amazing professor, Dr. Harriet Klein. I almost forgot her name. That's a function of my age. So I always had a thing for apraxia and autism.
Mhm.
I did my prompt certification with Deborah Hayden at Hospital for Special Surgery in 2001. That was, wow, a big, 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 amazing class workshop to take at that time. And I served on their board when Prompt Institute was in New York. So, no, this has been in my blood for a long time, Sharon. But doing it in the way that I've been doing I had a private practice for a very long time on the Upper East Side, which gave me a lot of flexibility to do treatment as I saw fit and wanted to. Coming into a research study where there's fidelity, so my sessions are being reviewed all the time. All of my sessions are being observed. I have research assistants that are like tallying productions. Like it's a whole big thing, and I have to stick to the way that the therapy is supposed to be done because that's how we show that it's efficacious, right?
Mhm.
So that was weird at
Yeah,
first.
I can imagine that.
Yeah, like a little like, oh, everyone's watching.
Mhm.
But this treatment and it's this study was 4 days a week. So when a kid is in the study, it's 4 days a week for 45 minutes. So this is intense. I would say half of what you said was true. I bumped it up a notch when I started with the treatment study for sure, like all of this. And childhood apraxia of speech has changed a lot over the years, how we look at it, how we diagnose it, how we treat it, especially. So I've been here evolving with the changes.
Definitely. And I totally understand that piece of being flexible and able to be flexible with what you're doing, whether you're in a system that just kind of is not breathing down your neck or you're in a private practice, right? There's room for kind of less structured, even you're creating structure, but you can change things as it goes. And here you can't pivot at all. This is a true study and you're giving the dosage at a certain amount of duration, frequency in a specific way, which is great because now we can learn more about apraxia. And speaking of apraxia, since we're going to be talking about that a lot, this is an area that I struggle with myself as an SLP. I find that there are so many children starting at a young age that have what we call reduced intelligibility, right? Or difficulty being understood by others. And in
Mhm,
graduate school, they teach you a little bit about that, about how it's not just reduced intelligibility because it's a motor programming disorder, right? And so basically the errors are very inconsistent, whereas with the sister or niece or cousin dysarthria, the errors are more consistent. But there's still a lot of mystery behind this because articulation, I feel like a lot of people in general don't necessarily love unless you're really in love with it. And then you have this other layer of all these individuals with reduced intelligibility, and
mhm.
people are really lost.
Yeah.
So, how do they become, or how do I become not lost?
So you feel that way because of the system,
Mm,
right? You and I both know we went to school and we got a generalist degree,
right.
which in many ways is lovely, right? We had exposure to adults and kids and, depending on where our placements were, we got more exposure, but we never really, you don't settle on something like a niche in grad school, right?
Yeah, that's absolutely correct. Yeah, yeah. No
What
specialized.
happens, like, you were in the Board of Ed, childhood apraxia of speech affects 1 to 2 in 1,000 kids.
Wow, that's
So
a lot.
it's a lot, but it's not if you think about your New York City Board of Ed SLP, right?
Hmm.
What are they going to want to do their CEUs and their workshops in what they're treating?
Right.
every right? Where are they going to spend their time and their money, right? In to learn more. It's not always going to be in apraxia of speech because they're not always going to be able to take what they're learning and directly apply it because maybe they have one kid on their caseload of 70 kids.
Right.
Maybe. So that's why you feel that way because we don't have to specialize in grad school and then we come out and this is a niche area, right?
Mhm.
And if we think about it, we have the umbrella of speech sound disorders, right? If we think that that's the umbrella. And honestly, I actually always loved our tick. Like our tick to me feels like math. It
Right.
makes sense. 1 + 1 = 2.
Yeah.
That adds up. Language always felt a lot more nuanced to
Mm.
me and ambiguous,
Yes. Yes.
which
That's
is
definitely
where
true.
I got this focus, like with the artic and apraxia. So you feel that way, and then it becomes, a self-fulfilling prophecy. You get the kids, and you don't want to treat them, not you.
No, 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 of course.
Because
Right.
you know that you don't have the level of expertise, right? So
Right.
you would refer out. I mean, this all makes sense, right?
Mhm.
And things have been changing so much. I mean, so much. And very recently that there's still a lot of well-intentioned SLPs putting out misinformation. Honestly, it's in our this day and age of just like quick bites and social media, and this is where people are going for their information. It's hard to now get the accurate information to the people who actually really need it, which is sort of why I've been doing our Instagram page for NYU Motor Speech Lab. That's been just like a passion project for me, and it takes up time. I know, to do all that, but just to get information out there that is actually accurate. So back to your original question, and then we could talk a little bit more. It's Apraxia Awareness Month. I'm so happy to be here. Thank you for giving me the space
Of
to have the
course. I'm so
conversation.
happy you're here, Nicole.
There are really wonderful resources for SLPs right now, and the one really amazing one. And Sharon, I would tell you to come. We do it in March every year. There's a few that happen throughout the year, but childapraxiatreatment.org, which is set up by the Once Upon a Time Foundation, they host a free workshop. And we're coming to you from New York. So in March, usually that first or second week of March weekend, we will have a workshop hosted by the Once Upon a Time Foundation, which will have therapists come from all over the country, sometimes the world. And it's a free 2-day workshop. You have to apply, you have to do a couple of things to get in.
Yeah.
But once you're in, it's free. If you don't live in the area, obviously you're paying to come to New York and to, for your lodging. But the workshop in and of itself is free. And if you watch Child Apraxia Treatment, their Instagram page, and if you go to their website, you'll see that these happen fairly frequently throughout the country. I think the next one that just happened was Chicago.
Okay. And
That
so
just
that
happened recently.
so you have the foundation that is in New York every March, right? And then you have also this child health apraxia of speech meetup that occurs every so
Uh,
often.
it's not a meetup, it's actually a workshop,
A
and
workshop.
it's a CAS advanced workshop that's funded through the Once Upon a Time
Ah,
Foundation.
okay.
What makes it free? It's capped. It's
Right.
capped at 50, I believe 50 participants per
Okay.
workshop. It's if like this is what I would say. If an SLP is watching or you, Sharon, are thinking like I could use a
Yeah.
little bit more training in this,
Yeah.
watch the space. I think applications open like sometime in January. You would do the application and then you would find out that you're accepted and you would come do this really incredible workshop where you would get a lot of information.
It sounds wonderful. And again, these are things that we don't all know about. And part of it is, like you said, we're not all necessarily even looking for it, even though we should be, because, it's hard to be an expert in everything, but we should at least be knowledgeable of everything because. Again, apraxia of speech is something that when I was a CPC administrator for the 3 to 5 year olds, every other day I was getting a referral that this child may have a apraxia of speech. Did they really? Right? It was hard to tell. So seems like it was just something that you have to even discern. And getting back to that, in terms of evaluating childhood apraxia, I've also found that difficult. And I know it's always suspected. We call it suspected childhood apraxia of speech. It's like you're not allowed to say that the child has apraxia, right? You have to say it's suspected. Is that
No,
like
you're allowed to say it. You're
you
allowed to
are?
say
Okay, okay. Politically correct. I don't know what's new. Everything changes these days. So I was worried that, I could get in trouble for that. But realistically you can. But so this you go in and you try to do a speech and language evaluation. And how do you really discern that this is apraxia? Not suspected, but actually apraxia.
yeah. Okay. So it's a great question. I'm going to tell you exactly what to do. First of all, apraxia is diagnosed by a speech pathologist. Everybody know that. It You can diagnose apraxia really at any age. You
Hmm.
don't have to be 5.
Right.
You can even really make the diagnosis in under 3 if the child has enough output for you to see the characteristics, and if they're imitating or they're willing to imitate
Right.
and sort of get in a groove with you where they can imitate you and try to attempt the target with your cueing, right? So one of the things we hear all the time is that you have to wait until they're 5 or you can't diagnose it before 3. It actually has nothing to do with age and everything to do with how much output they have.
Hmm.
So what we do in the lab is we will do a DEMS, which is the Dynamic Evaluation of Motor Speech Skills. It is the only assessment on the market right now that will make a diagnosis of childhood apraxia of speech that also has dynamic assessment in it, which means the target not just once. And you're allowed to do almost a little bit of therapy, it feels like, in between to see if what kinds of cueing help to get them to get the target
Hmm.
and how close they could get to the targets. It's a little bit different of an assessment. It's amazing, and I'm actually right now working on a training with Dr. Strand, who created the DEMS as well as the technique that we're looking at in our lab, on how to really use the DEMS. So we're working right now together on a 4-part series that will be on MedBridge, on
Wow.
what it looks like to really give the DEMS. I've given many over 6 years. So we would give the DEMS or I would give the DEMS, right? And that's me looking at, am I seeing the characteristics of childhood apraxia of speech? You said it absolutely correctly. This is a diagnosis. It's a motor planning and programming diagnosis. So the child knows what they want to say, and in absence of any type of there's no low tone, right? Everything looks fine with their articulators. It's like a glitch in the message from the brain to the muscles of articulation. Is about That's how we sort of describe it to parents, right? So therapy has to work on the motor planning and programming, which the therapy then looks different. And we're using principles of motor learning within our therapy sessions, which I could explain in a little bit, but I want to go back to the assessment piece. The DEMS isn't looking at the phonetic repertoire. So you would do the DEMS to look for the characteristics of childhood apraxia of speech, which are the ones that I think people are familiar with. The inconsistent prosody, difficulty with co-articulatory transitions or those movement transitions. Prosody is challenging, vowel errors, that groping. There's the Mayo 10. I mean, we could also go through that, but you're looking for these characteristics, right? Voicing issues, timing errors,
Right.
sort of sometimes there's a equal stress. So, and the DEMS really has all these characteristics laid out really nicely, right? So you would do the DEMS. You would then also want to do like a Goldman-Fristow or some type of assessment that looked at the repertoire, because that's not what the DEMS is doing, right?
Yeah.
The DEMS takes you through like a hierarchy with syllable shapes. So it starts with VCs, like up, it goes to CV, CVC, CVCV, and then it goes all the way up to like a word like lemonade, let's
Right.
say. Okay.
Yeah.
Then that's where you're going to see your characteristics, and you're going to get your repertoire. You're going to also want to do a language sample, and you're going to also want to, rule out hearing, and you're going to want to do an oral perif as well. Look at the structure, make sure everything is intact. The other thing that I really highly recommend is the ProCAD. Is Una Siegel and Kristen Allison. And I could share with you the resource. They're actually doing a big study on it now, but they have the ProCAD, which they have a research article that came out about it maybe in 2023 or 2022, but I use this all the time. It has a really nice decision tree, and it really walks you through differential diagnosis between dysarthria, which
Mm-hmm.
you were talking about as the first cousin,
Yeah.
and apraxia, which people tend to get very confused by.
Mm-hmm.
So this is really a wonderful framework that they have created, and I love it, and I teach about it all the time. And it really sort of helps you go through what characteristics are you seeing and what could this really be indicative of? Because we do know that sometimes they're hard to tease out. And the bigger point of like what you're doing with your work here with this podcast is children don't always present so neat.
Yeah.
They have a lot of comorbidities and lots
Of
of stuff
course. Yeah.
going on. And that's what
Yeah.
makes it even harder
Yeah,
to.
yes, yeah, and I was gonna get to that because also apraxia just by itself, without a comorbidity, which one can argue that with something like apraxia, it could lead to other things also, just because of the nature of the individual struggling so much with trying to communicate, right? I mean, that's always something that can lead to something else, but when it comes to something like autism, right? Or ADHD, autism and ADHD or ADHD by itself, the complexities seem to be a little deeper just because now you have to weed out what is coming from the autism. Like the first thing I can think about is that sometimes individuals with autism can be echolalic. Now, that's not necessarily anything related to stress or prosody, but sometimes the echolalia can sound a certain way that could feel like they're groping, or maybe they have limited verbal output in some cases with the autism that is not with the social communication. I'm going to get in trouble. Formerly known as Asperger's, no longer Asperger's. So when there's limited verbal output or the output is kind of atypical to begin with, such as with autism, is there a way to get around that?
So it's a really good question, and it's an important question. I know there's going to be a lot on this at ASHA
Hmm.
coming up. If anyone is going, we'll be.
Indianapolis this year. I'm like I'm going because I've never been to.
Oh, great. Well, so you come find me. We'll see each other in person.
Oh, amazing. Okay,
Yeah,
because when I saw Indianapolis, because I haven't been in years, and I'm
I've
so
never been.
strange.
It's
Yeah,
weird that it's
you
there.
know, right, right. It's like I don't even think about Indianapolis as a. I'm
No,
sorry to
never.
anybody who lives there. I'm so sorry. It's just that like I
No,
forget
yeah,
that it's a
very
state.
sorry, but no,
Yeah,
it's just it's never been there. Like I've
right.
been going forever,
Right.
so
So
I'll
I'm like,
never.
okay, this is a good reason to go. Like most people would say, oh, it's in, like the OT conference was in Anaheim. Like the average person would be like, oh, let's go over there. But I'm like, no, this is cool. This is different. Anyway, yeah.
So the first thing is this. Over the years, we've gotten a lot of referrals for the studies. So for this first study, the child could not have a diagnosis of
Hmm.
autism. Not because we didn't think it would be okay or anything. It's just that we
Right.
needed to really look at, is this an efficacious treatment with these kids that just had this diagnosis, so that then we could then try with other diagnoses and comorbidities, which is hopefully the plan coming up with the next study, because we are seeing that it is efficacious, which is exciting. But the interesting thing is, if you have a child on the autism spectrum who is nonverbal, if they are not imitating, we could suspect that the reason for their nonverbalness is apraxia, but we cannot make that diagnosis, because making a diagnosis of childhood apraxia speech, that's based on observations,
Right.
and we need them to be able to imitate, pay attention and imitate to make the diagnosis. So that's the first thing. Now, they don't have to have words, they could have approximations, and they don't have
Right.
to. I've seen many kids that didn't have any words
But
and
it's
had.
even the sound level, right? Even imitating sounds is where you can detect that motor programming or brain
Yeah.
mishap. Okay.
Yeah. So I've had a kid who had a sound preference for D, and everything was D and da da, but they would imitate and they sat, right? So it's the child you need to be able to see these characteristics, these observable characteristics. That's how we make this diagnosis right now. If the child is nonverbal or not imitating and cannot sit and attend for an assessment, you really cannot make the diagnosis at that time of childhood apraxia speech.
Mhm.
So I just want to put that out there. We've had a lot of recommendations for kids to be in our study who were not able to imitate. So then they can't even participate in the treatment just yet. I'm not saying in a little while they might not be a good candidate. I'm just speaking at the moment. And for those kids, they need to be on a device. I'm sure you talk about this all the time. Like those kids need to have a way to communicate,
Yeah.
right? Like,
Where
so
they
that's
see device.
always,
Yeah, I mean, right, so there's always some form of communication that you wanna establish for someone, right? And
yeah,
if an individual cannot present with verbal output at all, right, then you wanna, have an assistive device for them and or, reinforce gestures if you can to accompany, whatever's going on that they can show. But yes, the device is critical when someone is not really producing much. Yeah.
yeah. And I do screenings a lot, so I don't have a lot of time with families, and it's not where I should really necessarily be always putting time. But I talk to parents a lot about this because they were told something and they have a certain feeling, and the child needs to be able to communicate, and they're not communicating effectively verbally right now.
Right.
We're not ruling it out.
Yeah.
So I sort of see that I've seen that a
Yeah.
lot, right? So you have to be able to see the characteristics to make the diagnosis, which means the child must be able to sit and attend to an assessment. Now, I say that, don't get me wrong. Like I've worked with kids for my whole life. I've had many, many, many kids. It's not like they're not just sitting there and like, okay, Nicole,
Yeah.
whatever you want, right?
Right, right, of course.
It's
The
definitely not, it's
attention
definitely
right,
not
especially
that.
now, like, with screen time and everything, yeah, I mean, come on, it's fleeting at that.
Right.
Yeah.
Right. So, and I have worked with a couple of kids that have had an ADHD and it's been really good.
Mhm,
It's just we have to work with them and get them to really, the crux of the treatment is that we're working on our targets and blocks of practice, which means for that block,
mhm,
we're doing the target repetitively over and over and over again, and they have to be focused and really listening to and paying attention to my multisensory cueing. Are they with me? We call this conscious practice, right? That's what Dr. Strand calls it. If it's not going through the cortex, no learning is happening. Are they with me right now?
mhm,
If they're not, like sometimes what I've done is I'll say to the family, I think in a couple months he could be a good fit, but let him go back to his home therapist
mhm,
and work on these precursor skills that would have him be successful in this treatment.
right.
But like when we think about an autism and then an apraxia, how frequently are these two comorbid? There's a lot of different numbers that you're going to hear about this, and it's big. So
Yeah,
I've heard 30% children with autism have a comorbidity of apraxia as well, and I also heard a lot higher,
right.
somewhere up in 50 or 55, 60%. I I sort of feel like those higher numbers may not be accurate because it's the kids that are nonverbal
Yeah,
that are being given a label of apraxia,
right.
right? That we can't really make that conclusion just yet.
No, not yet. And but it's interesting, two things, if you don't mind me jumping in. Well, one was that, like you mentioned, how first develop these precursor skills so that you can actually engage in the study
Yep.
appropriately. And I feel like that is really important, specifically with apraxia, because you really need to have very specific skills. But it's no different than if somebody goes for a specific type of, let's say, mental health therapy like CBT or DBT or all these other things. And sometimes a therapist could say, just because I have a pulse in the therapy world too, well, this individual needs to build up these tolerance skills first, or they need to do this first, get their life in this kind of way first, and then they can really benefit. So for me, that's like what it reminds me of. Like you have to have certain baseline skills to really benefit. Otherwise, it's just not going to go anywhere. But the other thing you mentioned, which is fascinating about the comorbidity. Some say 30, some say 55. The nonverbal piece is getting in there somewhere where people are being diagnosed as apraxia, even though they may just be nonverbal, right? And that's and the other thing I see also is that autism sometimes is more prevalent now, especially with each passing day, an autism diagnosis becomes more prevalent. And a couple of podcasts ago, the last one that came out with Jennifer Volpe of Manner of Speaking, we spoke to that about like why is it that there's so many neuropsychs that reveal that an individual has autism or ADHD. I feel like every neuropsych report I read has one or the other or both together. So I wonder if that's also a contributing factor, that autism is diagnosed at a higher rate than it's ever been. But I don't know. I could be that could just be something up.
I don't know. What's
Yeah.
interesting is that most people don't know. We talk about autism on a spectrum,
Yes.
which you can't say autism and think one particular kid.
Right.
You and I both know this, right? It just looks so differently.
Yes.
It's the same way with apraxia,
Hmm.
which I think makes it more nuanced and even harder.
Hmm.
So, for instance, I in the course of this treatment study, I've had some kids where no words. I had one little boy, he was 6 years old. He didn't have any words. His targets were like mom and bye, happy, up, right? And I also have had kids where we've had phrasal targets, full phrases, right? Come on in, take it out. Still both had apraxia.
Hmm.
So I think that's also another nuanced thing happening here, that we have these kids in flux and in development, right? And
Yeah.
then we have, everybody is presenting a certain way. It becomes a little bit challenging. I'm constantly just saying, like, you have to just meet the kid where they are, and just work with them exactly where they are. So, like, with the study, because I knew that if they got into the study, they would only have 8 weeks of treatment. Not only, it's a lot, but like it's 4 times a week, 45 minutes per session, but it's 8 weeks. And once they're in and we do the assessment, the clock is ticking. I saw in some of these kids that, sure, I could have brought them on if I was like Nicole Kolenda private practice
Hmm.
and work with them and help them and get them to a certain point where then I could go in and do this treatment. But they don't want to kind of come to get this treatment the way that it is. Like, I wanted them to have the most of what they could get out of the study. I wanted them to hit the timing right.
Yeah. Yeah. Well, it is a study, right? After all. And with a
Yes.
study, you want everything to align from the
Yes.
beginning to the end. And if you're bringing in individuals who are a little bit more nuanced, that could corrupt the results of the study, right? The study's twofold. It's one to help, but also to also learn, right?
It's so interesting because so many times we've been like, we've learned so much from this child, or that's, every moment, even in its challenging moment or whatever, has really been a learning moment.
Hmm.
So you're absolutely right with that.
Yeah, and so this complex apraxia, which seems so complex, but now I know you're knee deep in it, and a whole history of just love and articulation, which you're in that group, right? You're in that group of articulation lovers, and this is so different and goes beyond articulation in a way, right? Because it's motor programming, it's the brain sending wrong messages, and there are a couple of myths out there that float, more than a couple, but a few that I've heard that I feel like don't really add up to what apraxia is, and I'm sure you've had heard many more than I have. But some include, okay, the child is having difficulty with intelligibility, they're apraxic, right? Or the child has so many phonological processes and atypical processes such as backing instead of fronting, therefore they're apraxic, right? Or have apraxia of speech or suspected apraxia of speech. The child hesitates a lot when they're speaking, and then because there's so many breaks and pauses, it's a motor programming issue, apraxia of speech. Are these things that you hear amongst many other things? Okay.
Yeah. So back to the suspected
Yeah.
situation.
Yeah.
You could really have a kid and really be unsure
Hmm.
because of how nuanced this is, right? And when we say, that's when we would say suspected. But in that case, you would take a motor approach to treatment.
Right.
You would act as if this was apraxia and treat it that way, which the therapy sessions look very different. Because if it's not, in a couple of months, they'll still make gains and you'll be like, oh, great. And you'll move
Yeah.
maybe to a more traditional approach. But if you do not treat apraxia of speech, if you miss it or you
Hmm.
misdiagnose it, and you're treating it with a more traditional approach, you're really putting the child and the family at a disadvantage.
Yeah, it's interesting that you say that because I think in our world, a lot of times from AAC devices, like we mentioned, to giving therapy in apraxia of speech where a child may not have it. It's suspected. A lot of times, individuals such as caregivers worry, will this impact my child negatively? And all these tools that we have, for the most part, unless it's completely a misdiagnosis, generally support the individual when it comes to communication. Like the AAC device, I know some say, well, that's going to take away from their ability to speak. Well, no, we're actually supporting them so that they can develop functional communication and not struggle and then
Right.
eventually wean off of it. So I feel like it's the same thing with apraxia of speech where some may worry it's suspected. So then what are we doing? This is not the right treatment. But in fact, it sounds to me, Nicole, and correct me if I'm wrong, that this type of treatment is so intense that if a child's having difficulty with articulation just in general, it may even be beneficial to them in a greater way than traditional articulation.
So I am like, because I love articulation and, doing this type of treatment specifically for apraxia for all this time, I'm
Hmm.
constantly thinking about how it's basically boils down to speech is a motor act, which we know, and the principles of motor learning. Edwin Moss et al., 2008, came out with their landmark paper where they really started talking about the principles of motor learning and overlaying it onto speech. But before then, we weren't thinking, and it's so strange to me to even think this, we were not thinking about speech as a motor act. So
Mm.
principles of motor learning have been around forever, and
Hmm.
especially in our allied health professional fields like PT and OT and movement science disorder and all of that, obviously, right? But we really only started using this lens to look at speech production in 2007, 2008, which I know because I've been experienced it in my career, but it's kind of like, really?
Yeah.
Speech is motor, which back to your point, articulation is motor. Right now, me talking, I'm planning the motor movements to talk to you clearly, right? Like that's what
Right.
I'm doing. And it's sophisticated and there's a lot happening, but I'm doing it.
Yeah.
So, what I have thought a lot about in my head while I'm doing all this stuff, and I talk about it a lot, is taking these principles of motor learning and the way that we organize our practice in childhood apraxia of speech is really beneficial to traditional articulation as well. By
Mm.
what you just landed on and what you said.
Hmm.
It's speech production. So it's helpful really to organize your sessions, even your traditional, articulation sessions with a motor lens because it is a motor act.
Even though dysarthria, for example, one can argue, oh, but it's not motor programming. It still is motor.
It's still motor.
It's just the articulators are not working or in a functional way for some sounds, right? But it's still all motor. Yeah, I think there is some confusion that with that because I do remember eons ago, not to date myself, but a while back in grad school taking a motor speech disorders class. And I remember that, it just touched the surface and there were a lot of cases that were brought in related of like even to dyskinesia, tardive dyskinesia, like all these other things that were going on. But I feel like it never broke down. And again, I hope they're doing it now, but like as all these articulation challenges as being primarily motor. Even though it's motor speech disorder. So I don't know. I think that a lot of people come out of schooling and unfortunately, things change and evolve, but we're like not given necessarily the full scope.
I know, which is really why I love teaching this 7-week elective class on pediatric neurogenic motor speech disorders because people don't have this information. You got to get the ProCAD down. You're going to be like, oh my God, I'm going to email you the paper.
Okay.
And I have this because what Jenya is doing in that paper is really highlighting how there can be overlap with certain characteristics, but there are characteristics that are really more primarily dysarthria, like voice loudness and difficulty with voicing characteristics. Also, like you talked about, like with the consistency piece, like dysarthria, the child with dysarthria has low tone. In my mind, how I distinguish them, right? There's sometimes there's even an open mouth posture. Their errors are predictable and they're relatively consistent. The the child with childhood apraxia of speech doesn't have and you could have a child that has both, right? And you would work on the skills that were more the challenges that were more face forward. They had inconsistencies in their output, which is why, like on the DEMS, you don't just say the word once, you have them say it twice. And I don't know if you've ever done this before, like even like giving a Goldman Fristow.
Hmm.
Target word is house, right? The kid says hout. So you'll go because you're following the protocol and you'll mark it wrong, right? They didn't ask for a T. In your head, you're thinking, "I'm stopping," right? Whatever.
Yeah.
But if you just went back and said, you know what? You said hout. Could you try this with me? House. Maybe you gave them a little tactile cue, like my one, house,
Right.
right? Can you keep your tongue up? Can you elongate it? Whatever you're going to say. And you see that they get it. Isn't that amazing information to have?
Of course, it's amazing because that totally alters the treatment plan for this individual because we know now that they get it. So now it's all about can they maintain this in other contexts as well, right? Besides that, or maybe they really have it but made a mistake, which is why the two trial thing that you mentioned is great. I
Yes.
think that the Goldman Bristow has been around for so long and the protocols are just so black and white sometimes, even though I understand with evaluations, you have to make it a little more black and white.
You could still do it. Like you could still follow it to the T, but just like for your own information, are they stimulable for it? What
Yeah,
cues are going to work for them? In a
right.
case like just doing the Goldman-Frister, we call that a static assessment. You turn the template, you have them say the target, right? You transcribe how they said it, and you keep it moving.
Yeah.
There's definitely a value add in that type of assessment, but a dynamic assessment is an assessment where you go back at it. You
Mhm.
get cues. You get to see like for the treating clinician, like, oh, that kid did not want me to touch them. Or
Right.
that kid was really responsive to, visual and gestural cues, but not tactile cues.
Right.
Start to like get a whole thing on the kid, and it's so much easier to work with them after.
You know what I think it is also? I think that with testing, the word test means you can't help somebody, right? You can't prompt them because then you're giving therapy and you're not really assessing them. But to your point, dynamic assessment is looking at a lot of different things, making observations and prompts aloud. And I think that one of the issues I found is that we were always taught to evaluate in a way where we look at stimulability, like you said, to see if the individual even has the ability to produce the sound. Because if they don't, then we have to do some other things before we even get there, right? With manipulation of the articulators or whatnot. I think a lot of students and professionals are taught that if there's a sound they're having difficulty with, then we should try to see if they could say it in isolation, but not necessarily repeat a word that has it. And I think that whoever's listening, I think this is very important because I don't think I've heard it phrased in this way where it's kind of like, okay, you make that error in that word on the exam, on the Goldman Firsto test, repeat it and try to do it like this house, right? I think that's super valuable, but something that still is not happening often.
Well, also something that comes to mind to your point with like the isolated phonemes. So the one of the bigger differences with CAS treatment and traditional articulation treatment is that we're not working on isolated phonemes. We work on target words because we have to work on the movement gesture, right?
Mhm.
And the reason why we do that is because if you take a word like be, right, and then contrast it to a word like boo,
Mhm.
even if you're just looking at my lips right now, Sharon, or if you say it yourself,
Right.
my B for B, my lips, anticipatory, in anticipation of the E, that retracted vowel, my lips are retracted. But for boo, in anticipation of the rounded vowel that comes after, my lips are rounded. Well, what do you know? The motor plan is different for those two B's.
Mhm.
So just working on B in isolation isn't helping.
Right. The vowels really change everything. The high, medium, low vowels, it changes everything, especially with the R, but I won't get into the R side.
No, jumping into that. That's a whole other topic.
That's for part 2 is the R. Maybe you can solve all the world's problems
No,
with that
I
R and
wish.
R. And people, it's sad because a lot of clinicians steer away from that if they have the option in working privately. And I've taken it upon myself a couple of times to take on those cases. And
Yeah. Good for you.
It is very challenging, but at the same time so rewarding when you see the progress that is made and how it really does transfer from one context, even though there are like 25 different contexts that are can be manipulated. So getting back just to this amazing therapeutic approach, the study that you're engaging in, you're so like passionate about it, and it sounds like you really care about these kids. Like you really want them to like succeed. Not that other people don't, but there's like
Right.
a certain down to earth piece that you have that I noticed when I first met you in 2018, apparently. And so basically, you're using this DTC approach.
DTTC, Dynamic Tactile Temporal Cueing technique developed by Dr. Edith Strand. She outlines it in her tutorial paper, which came out in 2020. And
Mhm.
it's an amazing paper to read, to learn how to do, like, she just spells it out. Edie Strand is a clinician. If anyone has ever seen her speak, or she's just an amazing clinician and researcher and brain.
Yeah.
But what she loved to do was work with people and kids, and she created this technique. So dynamic temporal timing cueing technique, aka DTTC.
Yeah, I definitely have heard of it, but I haven't really utilized it. And for those listening, this sounds like a good sequenced step by step procedure to address apraxia. Speaking of which, prompt. You said you were prompt trained before
Yep,
even a lot of other people got prompt trained.
yep.
And now prompts all the rave and people love prompts. And it's interesting because, like everything else in our field, you'll have one person saying something's great and another person saying it's not that great. And they're just repackaging it, this existed before, which is true in some cases. But prompt is very specific and very scientific. Is prompt also something that can be used in conjunction with DTC for individuals with apraxia?
It's a great question. So we have our proverbial toolboxes, right? Me, you, all the other SLPs and, allied health professionals that we drag along
Hmm.
to every clinical interaction, right? And it's no different with CAS treatment, right?
Right.
So prompt, we know, tactile kinesthetic cueing technique, right? So we're touching the articulators, they have their framework. Prompt's been around for a very long time. DTTC is new. You're going to start to see now these results of our studies coming out. It's our study. There's a couple of caregiver studies. There's a study
Wow.
coming out from Australia
So
on
you're the
DTTC.
pioneers. You're in the part of the pioneer
Yes,
generation of this. Wow.
they're going to be coming out. It's really exciting.
Yes.
We'll have a talk at ASHA going over what our
I
preliminary.
can't wait. I can't wait in
Yeah.
Indianapolis to hear about this.
In Indianapolis. But the interesting thing is, it's like DTTC, there is a place where you can use prompt because you are using multisensory cueing.
Mhm.
So it's not, for as much as there's a hierarchy that you follow, it is not cookie cutter. It's about you. I always tell the therapist, like for us who have been in it for a minute,
Mhm.
who've been doing it a certain way, and this is all weird and different. We don't like for instance, my 45-minute session, I have no more than 5 target words. That's it. I'm working in blocks of practice. So if the target word is me, I'm doing me in a block over and over again, 10 to 20 productions.
Mhm.
And then I'm cycling through them and I'm getting, I don't know, anywhere from 150 to 300, 350 productions per session. And I know that because we have to tally them.
Which, by the way, even though many of us have veered off in different directions with our tick therapy and traditional artic therapy, even traditional artic therapy says what?
You wouldn't get anywhere near that with a
No,
traditional.
but technically it does state if you're following articulation therapy that drilling, right? Constant drilling and consistency of drilling is critical in order for individuals to really learn how to change whatever it is, whatever sounds or whatever verbal output needs to be changed. And I think that unfortunately over time and with the constraints of the system, so many other targets are being introduced and drilling isn't really being accomplished because you're trying to like cram things in one session. So it's so great. It sounds like that it has to be like 5 targets
No more than 5. Sometimes I start with 3 and that's it.
and then repetitive over and over and over, right? Okay. And
Yep.
in this DTTC, because again, our tick, I know you love it, but some of the kids don't love it, right? So if they're getting bored or anything, is there room for anything in terms of motivating them or getting them to attend?
Yep. So I call this the parking lot method.
Okay.
And, yes, but what we have to remember is we do not want the child on autopilot.
Hmm.
So The same, I would say, which is also why I love traditional articulation therapy. You can do whatever the
Mhm.
child wants to do. You just have to get your practice in, right? So
Mhm.
with DTTC, we're working on our word. You're looking at me, you're following my cues, we're going back and forth, and we're working on the word. And now we're going to take a quick break.
Mhm.
Maybe we're parking lot method. We're going to earn 5 cars and then we're going to get the tracks. And by the end of the session or, in between, we're going to be able to play a little bit. So wonderful. You just said that word. Here's the car. Take a look. This is the one you wanted. It's green and shiny. And okay, we're going to put it in the parking lot. And now we're going to get another car. But here's our word that we're going to work on. You see how it goes.
Yeah.
It's not play therapy. No,
Right.
it is not play therapy.
Right.
But I make it fun.
Right. And Nicole, I wouldn't underestimate you. You are a fun person. You are a shining light. I don't think this is boring at all. It's just that I know that some students, when it comes to these drillings, right, they get a little bit frustrated. But yeah, it does sound like you're at least bringing energy into it so that it's not just, okay, drill, drill, drill. At the
No.
same time, play based is not going to cut it.
There's a place for play.
Hmm.
The nuance with play is also, is it play based in that you're working on play goals? Or do you just mean that you're using play as a reinforcer or to work on language goals? These are two different things. If your goals are play based, I'm talking like Westby, play
Yeah.
scale, social thinking, look up Nancy Tarshiss's work, like,
Yeah. I had her on here.
yeah,
Yeah.
I mean, she's amazing.
Yeah.
That's a different type of therapy, right?
Right.
You're going to have play goals,
Right.
right? That's not what this is, but you can also use play as a reinforcer too.
Right.
People get a little bit confused with this. So
I
I
agree.
use play. The one thing with motor speech therapy is that you don't want the child to engage in negative practice, meaning you don't want them to say the target over and over and over again incorrectly, because we don't want to lay down a motor plan for a target that is incorrect, which is why when we're teaching the skill, we don't want the parents at home working on the words, because we don't want the kid at home saying the word over and over again incorrectly, right?
Correctly, right, right, and you don't have surveillance cameras inside the home or
No,
recorders,
but
you
know.
don't tap the homes, yeah.
No, but like you're working with them, they don't have it, right? So, but if they're
Right, right,
not getting it, then you
yeah,
wouldn't work on that word.
right,
Or like, because you're not going to sit there and have them do something that they're not, it's not accessible with the cueing, right? So you would take that word and you would not work on it for that time. So it's like we go back to that boringness or that feeling of vulnerability
mhm,
or that feeling of this is really hard work and I'm not getting anywhere. They are getting somewhere. It
yeah,
is hard work.
right, and you'll have the article soon to prove it, but also in terms of I'm glad I brought up the play because, I took a break from clinical for a few years, but I always, had my feet somewhere in there, and then I come back into clinical and I'm observing, different people around me in different contexts, in different settings, speech therapists, occupational therapists, and it seems like play is so important because I know people are on their screens a lot or manual labor is not such a thing anymore. But I find that yes, these individuals don't have play goals, but yet play is is becoming like kind of the foundation of the session when the children are younger. Like so, for example, until like third or fourth grade, essentially, like play, and then I don't know what your thoughts are about this. I'm just curious, just since I have you here right now. But like, then there's also this free time where it's like, okay, like you did this, now you get to play for like free. Here you go, like do whatever you want. I think that's beneficial in some ways, but on the other hand, I feel like, but these kids don't really necessarily all have play goals.
For my session, I just always want them practicing.
Hmm.
So I'm aware that that's not possible. So that's why I think about it like for people who go to the gym when you're working out, right? Let's say you're doing a set.
Yeah,
You're working hard in
sure.
that set. What happens? You need a break after before you move on to your next set, right? This is exactly what it's like in motor therapy and motor speech therapy. You're working hard in that block. So you recognize that we need a break. But the idea is that you want to transition them right back to working hard. This is how I'm getting 300, 400
Yeah,
productions, in my session. Free play, like I'll follow the child's lead and do whatever they want. We're taking a little bit of a break, but I'm still embedding. I mean, we're speech
yeah,
pathologists, right?
right.
There might be words that they've gotten that I'll check to see how they sound in spontaneous
Mhm.
production, right? Or like, I don't know, that we don't turn that off,
Right. It sounds
right?
like when you're going to the gym and you're doing the elliptical, which lately I found myself doing more just because I've gotten a little bit more tired, versus, let's say, going on the treadmill and then inching it up until you reach maximum intensity, meaning which one are you going to do? It sounds like it's going to be more of the treadmill, right?
I mean, for motor speech sessions, the point really is to work hard and to lay the motor plans down. The intensity really benefits the child. This is what we're seeing. That being said, it doesn't mean it's not fun, but also the kids aren't robots, neither
No,
are we as the therapists.
no.
So you take what you have, when they're in front of you, which could look different day to day.
Do you mind if I take a detour for a moment? I'm being mindful of time, so I know you have to go, just let me know, but I really wanted to also ask you about a podcast that you had started that was very inspiring to me.
Sure.
It's just a testament. Oh, you smiled, so you wanna talk about it. Okay. So it's just a testament, just even because it was called, and it's still, you're still working on it a little bit, right? Voice for
Yeah.
Possibilities, and, even the word Voice for Possibilities just is a testament to how you really care about individuals having a voice, no
Yes.
matter where they are in life, whether they're nonverbal, whether they're having a tough go around because life is getting really challenging, but to communicate, because communication is the foundation of everything we're talking about, right? We want to get everybody, it's a human right that everybody should be able to communicate. So can you just like share with us a little bit about how that got started and how you were able to bring on, amazing guests and host this? Did you ever think you were going to be this podcast host that was inspiring so many people?
So hold on. I'm gonna put in the parking lot for 1 second. I do want to share something with you. So the kids come back for post data collection.
Okay.
So part of our design is, are they retaining and generalizing the skill that they learned in the treatment? So we have them come back 1 week after therapy ends, 8 weeks, and sometimes 16 weeks. And we do a bunch of tests with them. And something that I started telling Dr. Grigos as these kids would come back 8 weeks later, 16 weeks later, sure, I could do the assessment and I could do the kinematic analysis and I could
Hmm.
show on paper, that they're making gains and they sound amazing. But what wasn't captured was what I would call the swagger effect.
Mm,
The way that they come back into the clinic, their shoulders are back, they're confident, right? They're like, come in, like, who is that kid? They're talking so much more because they're comfortable, right? This is the profound effect that we've been seeing with these kids. And that's a very hard thing to write about in a research study.
right. The swagger effect.
Right, how do you take data on that? But that's been the best thing for me, like, when the parents email me, a picture of their baby on stage singing, and they're like, they never would have done this last year, or, one of the little girls, Nicole, she got an award for most talkative. Like, I can't believe it. Like, these are the things that this is why I love what I do, and it's, like, for all of us, right?
Yeah.
It's just to feel like you are making a difference in these kids' lives.
Yeah.
Gosh, that's, like, really incredible. So I feel like the opportunity in the study is at the intersection of, I love being a therapist, I love contributing to research, I love contributing to the field in a bigger way.
Yeah.
But really, like you, I like being connected to the clients and the kids
Hmm.
and the families. And I love walking through this journey with them, even on the hard days, really, because it's always just been so rewarding at the end.
Yeah, and I think it's important also to emphasize confidence because a lot of times it's not measurable, right? I mean, I'll write it maybe in a report and I'll explain that the child has become more confident, but for the purposes of research, you're not going to say, okay, they're empowered now and they're confident. It's not as measurable, but there is data, a picture being sent to you where someone who couldn't really speak before or articulate their ideas or was afraid to share is now singing or
Right.
dancing on stage. I mean, to me, that's pretty much everything. I
Right,
mean, from my
exactly.
perspective. Yeah.
Yeah. So I just wanted to share
Yeah,
that.
I love that. Yeah.
One's full circle. And in terms of the podcast, so Um, the pandemic started and I was, trying to think about I was working from home like everybody else and
Mhm.
trying to think about something I could do that would just for women, inspire women. We learn through women's stories, and I wanted to try to just I like talking to people and I like hearing their background and their stories and sharing just how we're all moving through life. And right before I dropped my first season, so I had recorded the episodes, I was diagnosed with breast cancer. And it made me, and so we're at like 5.5 years ago. So it made
Yeah.
me want to more highlight women's stories, struggle, and, new moms, and just, everybody to empower and lift up other women. So it's for me, it was really women centric. I didn't really have any men on because I don't love men.
I'm sure you did.
Yeah, I absolutely love my husband, but I just wanted, we work so hard and we're dealing with so much and we care so much. And I wanted it to be a support system for that. So just showing what's possible, even when things maybe sometimes feel impossible. And then through the podcast, I was able to just share a little bit in the conversations, just like my journey with cancer treatment and having kids and working and, what that sort of looked like. So I loved doing it. I haven't recorded a new season. I've been really busy, but I
I
have
really
five.
want you to.
Thank you.
Yeah, I would listen to all the episodes just because I liked it. It resonated with me. It was just very inspiring.
I appreciate your words, but I mean, look at the work that you're doing.
Well, yeah, but I still like your work. But anyway, no, but the reality is it's interesting because I remember because I remember seeing messages on LinkedIn and everything, and I was just so surprised. And I hope I reached out. If not, my apologies. But I remember just thinking, oh wow, she has this diagnosis. She has to work through it now. And then she's also doing a podcast at the same time. And I just thought, wow, what a badass. Like
Yeah.
that is really not easy to do, and at the same time, it sounds like your diagnosis was provided to you after you already had this idea.
Yeah.
Wow, that's wild, and that's also fascinating because I wonder if the podcast helped you in any way get through some of those tough times, just speaking to other people?
I think some of the conversations, some of them I had already recorded the first season. I had already recorded the first season and then I put it out. I believe, but it was already there,
Yeah.
everything's already happening. There was a lot of conversations that in a way were very cathartic for me. Like I had a grief expert on and it all of a sudden I was like, duh, I'm dealing with grief.
Mm, yeah.
I'm grieving the old me, right? Like, duh, like, I know that's kind of obvious, but I don't know, like, so there were definitely, or like, this conversation, and this was the point of why I wanted to do it. We can see ourselves in others if,
That's true.
and if we share, we don't always all share, and not everybody is comfortable, but just talking about how people creatively pivoted in the pandemic or how people were dealing with their home situations and
Yeah.
some women were, coaches and just some had, just beautiful stories of rising through things that were really challenging and just that in and of itself is inspirational, I feel like.
I feel like there's a theme with you, Nicole, where it's all about empowering others, whether it's in research with the children, with the families, and getting them to build up their confidence. Whether it's, okay, you have this diagnosis that's life changing and you're grieving the old you, and then you have a podcast that's empowering women. It seems like you're just such a big advocate in the space of trying to lift other people up. And I feel like that's really, really, truly amazing because there aren't that many people that are able to consistently do that in every area of their life.
Oh my God, I so appreciate the words. Wow.
Yeah, and so and I knew that when I first met you, but we won't get back to that. But anyway, so regardless, thank you so much for sharing everything about apraxia. There's so much more. I feel like we could do a part 2 on this if that's okay, especially after what?
There's a lot more, definitely.
Yeah, I would love to do a part 2 because I think there's so much and it's hard to explain, especially to people who are just learning about it. There's so many layers to it. The research study will be coming out soon, which is really exciting. And you'll be sharing this in Indianapolis, which is really exciting. I'll be there cheering you on and listening. But thank you so much also for sharing so many resources and specifics of the types of treatment and answering some of my questions, which were a little bit more complicated in the way, I was asking them. But really, I feel like this leaves me off with a much more clear, a little confused still just because apraxia will always confuse me, but a much more clear understanding of apraxia and how sometimes it's okay to treat apraxia when you're not even sure if it's 100% apraxia.
Yes.
So I
And
really do
also,
appreciate that.
I think too, like it's the same with everything. If you're a parent listening, if you're a speech pathologist listening, if you're a parent, you want to make sure that you get the assessment and the treatment by someone who has experience with
Mm,
speech.
right.
It goes with anything, any type of anything that you would do. You just want to make sure that that person is specialized in it. And how do you know? You ask, right? Or you get a referral. And then for the speech pathologists, like, please, 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 please follow our Instagram, NYU Speech Lab, follow Child Apraxia.
Yeah.
And like follow, these are really, we're really trying to put out really good information in the motor speech world. We have a whole May motor speech takeover where a bunch of motor specialists are doing posts every day. So that's really been a lot of fun. Dr. Jen Moore is spearheading that. So it's like there are resources out there, but also I am so happy if anyone wants to email me, nk7@nyu.edu, or reach out to me on social media.
Yeah.
Instagram. I am an open book. I take the time to respond to anyone. Like if you have a specific question, reach out.
I love how there are no barriers around you. It's just like email me, that's it. You don't have to log on to the website and then log in name,
No,
email. No, you're just like email me. I'm
yeah.
gonna put the email address in the show notes, obviously. And you said also there are a few other places where people can follow you and follow kind of the research evolution or how it's going.
Yeah, so I would follow at NYU Motor Speech Lab on Instagram. If you want to learn more about me, I have a website, NicoleKolenda.com. Child Apraxia Treatment is where you'll find the information for the childhood apraxia speech advanced workshops and a lot of information for parents and adults, and it's all free.
Mm-hmm.
It's a
That's
lot.
amazing.
And Apraxia Kids is an amazing organization. We're going to be presenting at their conference in the beginning of July. It's also a virtual conference, so you could join and have access to really amazing classes. And that's happening now. Like you could register for that now, apraxiakids.org. So there's a lot of information out there. You can get your questions answered.
Amazing. And someone said recently that, or two people that I had on this podcast said that the way that they gauge how things are being recognized in speech and language pathology or how things are moving is ASHA really including talks on it. Do you find that ASHA will be having a number of talks on apraxia of speech?
Yeah, so I'm actually an invited speaker. And I've also been reviewing submissions, so there's a lot of just good stuff that is going to be at ASHA.
Amazing. On
And like
apraxia.
on Apraxia, and I also like there's a lot of stuff coming out. There's Brianna Waldrop, who is a really great Apraxia expert, but also works a lot with autism. Like this intersection now is really starting to come out, and there's a lot of stuff out there right now. But I know at ASHA, if this is what you're looking for, there's going to be stuff there too.
Amazing. Thanks again, Nicole. I learned so much. And for everybody listening, I'm sure they all have such great takeaways from you. And just thank you for being the inspiration that you are and really trying to help and move people forward so that they can reach their voice.
Thank you for having me.
Thanks for joining us on Unmasking Social, where we neurodiverse advocates and those who support them explore how real friendship begins when we start showing up as ourselves. If today's episode resonated with you, please share it with a friend, leave a review, or follow me for more conversations that provide information on neurodivergent ways of thinking, communicating, and connecting. Until next time, keep staying social.